Hello, everyone. So today I have invited Dr. John Felix on our YouTube channel. This will be a collaboration between PharmD and MEDODRIX. And our today's sessions will be on antimicrobial stewardship implementation in hospital and the role of clinical pharmacist in antimicrobial stewardship. So before we start, I would like to ask John Felix to introduce yourself to the audience.
Okay.
And over to you.
Yeah. Thank you so much for the opportunity. Let me say about Mohammed Adnan Shaikh. So I know him from a long time. He has been in our MEDODRIX as volunteer, and also he's one of the person who have joined almost all the programs at first when we have started MEDODRIX. So thank you so much for being a part of MEDODRIX too.
Thank you. Thank
So
you so much.
today, let me introduce myself. I am Dr. John Felix. I have completed my PharmD from Tamil Nadu Dr. MGR Medical University, and I have worked as a clinical pharmacist at MEDODRIX International Hospital, and currently I'm working as clinical pharmacist at KIMSHEALTH Hospital, Nagarkoil. And I also completed my AMS certification course from Manipal Academy. So that's it about myself.
So yes, you can please share your screen.
Yes. Screen is visible, right?
Yes.
Yes. Okay. Okay. So today our topic of discussion will be Antimicrobial Stewardship Program implementation in hospital from zero. So from zero, what I just want to say is I just wanted to emphasize that Antimicrobial Stewardship Program can be implemented from in a hospital, any healthcare setting where you have a limited infrastructure or a very limited facility too. If you don't have any background of antimicrobial stewardship in your hospitals, you can just start with focusing on one topic, and then day by day you can implement more in the field of antimicrobial stewardship. So just wanted to emphasize that from the first slide. Like many people think that without having any of the facilities in the hospital, how can I implement antimicrobial stewardship program? But it's not like that. You just wanted to focus on one topic after a proper analysis, and just try to implement one thing at a time, and that will almost it will help you to implement the antimicrobial stewardship program. So my focus of the day would be will be covering the introduction, importance of antimicrobial stewardship, and why a clinical pharmacist is involved in the antimicrobial stewardship program, and what would be the roles of a clinical pharmacist, the initial steps, basics, and the committees involved, and monitoring parameters both in inpatient and outpatient wards, and also the audit and feedback. So definition, first, almost all the organizations have a limited or they have the same kind of definitions. First, we will see about the definition given by the World Health Organization. The World Health Organization says that it is an systematic approach to educate and support healthcare professionals to follow evidence-based guidelines for prescribers and administering antimicrobials. So, actually, both we have one more definition from one second. Yeah, we have one more definition from CDC. They also says that it is an effort to measure and improve how antibiotics are prescribed by clinicians and it is used by patients. So both have a similar mode of definition. Like World Health Organization emphasizes that we need to provide an evidence-based guideline for the prescription of an antimicrobial, and it is also important to educate the healthcare professionals regarding the antimicrobial stewardship program. And Center for Disease Control says that we need to improve how antibiotics are being prescribed by the healthcare professionals, and we should also give an awareness to the patients or the public regarding the use of antimicrobials. So, antimicrobial stewardship refers to an coordinated effort within a healthcare setting to ensure that the antibiotics and other antimicrobial medications like antibiotics, antifungal, antiviral. These must be prescribed appropriately, and it must be prescribed only when it is needed. Like, without confirming any kind of bacterial infection, it is not recommended to advise antibiotics. And the antibiotic which is advised should be in an appropriate dose. Like, it sometimes if meropenem tds is a recommended dose, some prescribers may advise it for bd or something, so which will not work. Actually, it will lead to antimicrobial resistance only. And it is also important to maintain the duration of antibiotic appropriately. And these programs aim to optimize the patient care, and it is also important to prevent the side effects associated with the antibiotics, and which will also slow down the development of resistance pattern in the hospital, and which will also spread the multi-drug resistance organism, right? So this can also be limited. So as I said earlier, starting from zero mean it is like you can start this antimicrobial stewardship program at any facility which does not have any background of antimicrobial stewardship. The primary thing is many hospitals, like most of the NABH accredited hospitals, will have these policies and guidelines, but some hospitals lack this. No, if you don't have a antibiotic policy and there is no appropriate antimicrobial stewardship team, and if you're seeing a high empirical antibiotic use in your hospital, and if the restricted antibiotic usage is irrational in your hospital, and there is no proper treatment guidelines, then it is like you can implement the antimicrobial stewardship program from here also. So we'll see the step by step process of implementing it. The initial thing will be baseline assessment. You cannot start just by implementing the antimicrobial restriction policy or something, anything. You just always need to go for an baseline investigation. You should know what is lacking in your hospital. Like, your hospital may have many facilities, but the prescription policy of certain antibiotics will be irrational in some circumstances. So you should know where you are lacking actually. So only after knowing that, you will know the gap which is lacking, and from that you can make the guidelines, antibiograms, policies, and then you can make interventions. You can educate, and again, even after educating and implementing few policies and guidelines, you need to focus on what is lacking again, and it is a continuous process. You need to focus like throughout your journey. You just wanted to make changes day by day. And sorry. Okay. So AMR, antimicrobial resistance. So antimicrobial resistance, I hope many of you might know, but just I wanted to give a brief introduction about this. When the antibiotics are actually intended to kill the microorganism or the bacteria. Sometimes the antibiotics will not be able to kill the bacteria. We call it as antimicrobial resistance. So this occurs when the bacteria, virus, or fungi and parasites evolve to resist the drug that is designed to kill them. And obviously, if that bacteria cannot be killed, the infection will be harder to treat, and which will also increase the risk of spread of illness. And of course, if it is a pan resistant organism, the patient will of course die. And this is a graph which shows that the beta lactamase is actually an resistance enzyme. The spread of this resistant enzyme has been evolving since years. And also, the AMR could cause 10 million deaths by a year by 2050, which is a paper published in Lancet, which says that about 2000 in 2050, about 10 million people will die because of the antimicrobial resistance. And also, this graph shows that Asia is the leading one, where more people will die because of antimicrobial resistance. As of now, we know cancer is the leading cause of death, which is around 10 million. And by 2050, the antimicrobial resistance will be equal to the cancer deaths. and importance of antimicrobial stewardship. As we have seen earlier, we need to combat the antimicrobial resistance
Sorry for
first.
interrupting you in between.
Okay.
Uh, I guess,
So it's okay right now?
yeah, it's fine.
Okay.
Great.
So, as we have discussed earlier, antimicrobial stewardship program is primarily aimed to combat the antimicrobial resistance. And also, of course, if the resistance is reduced, the patient's life will be saved and the patient will be, of course, happy. We will have an improved patient outcome. And the third point would be safety and harm reduction. If we go for an lower end antibiotic, always it is safe. We can reduce the harm related to the antibiotics. And the fourth point will be cost effectiveness. For example, if you are having an infection, a common bacterial infection, where the organism is sensitive to some basic antibiotics, you will cure the cure the bacterial infection with the normal oral antibiotics like amoxicillin clavulanic acid, which will cost around 300 rupees for the entire course of therapy. And sometimes, if the patient is having an multi-drug resistant organism, these antibiotics will not work. We will go for some higher end antibiotics like meropenem, and sometimes you have a new antibiotic called Emplavio, which is a combination of Astrionum avibactam. The each vial costs around 8,000 rupees, and you have to give 4 doses per day. And just think of it. If the each vial is around 8,000 rupee, you need 4 vials per day, which will cost around 35,000 per day. And if you need to give it for 7 days, of course, it is around 2.5 lakh for the antimicrobial therapy. See, what's the difference of the cost? So it is, of course, if the resistance is reduced, it will be cost effective and healthier tomorrow. Okay. Why clinical pharmacist? Clinical pharmacist always plays a vital role in the antimicrobial stewardship program. Most important being the dose optimization. It is the role of the clinical pharmacist to optimize the dose based on the renal impairment or renal function, then hepatic function, as well as it is also important to dose drug if the patient is on hemodialysis, and if the patient is taking some antibiotics like ticoplanin, then it is better to dose a drug based on the trough level. So these can be done only by a clinical pharmacist, most probably. And then de-escalation. It is another role of clinical pharmacist. Whenever it is possible, it is better to de-escalate the antibiotic. If the patient is on meropenem at first and the culture result shows that the organism is sensitive to piperacillin tazobactam, you can go for piperacillin tazobactam. This de-escalation can be performed, and then IV oral conversion. Also, it's similar to de-escalation. When the patient is stable and he can take oral foods, it is better to convert to oral tablets. For example, if the patient is on piperacillin tazobactam, then you wanted to convert to oral, you can choose amoxicillin clavulanic acid based on the culture report. And audit on antibiotics, you do a continuous audit on antibiotics, and monthly basis or twice a month you make a report on it, and based on the report you can change or modify whatever currently is in your practice, so which will improve the antimicrobial stewardship program. And of course, guideline development is another part. Based on the sensitivity pattern of your hospital, you make an guideline like what antibiotics can be given empirically for an respiratory tract infection or in case of pneumonia, and what antibiotics can be chosen for urinary tract infection. Like that, you can make a guideline so that the hospital can follow. And it is always better to have an guideline for your hospital based on your antibiogram. So for example, if I am in Tamil Nadu and you are in Kerala, the resistance pattern will be so much different in Kerala. So it is always better to have the treatment guideline based on your hospital's own restriction, resistance pattern. And this is a study published, the role of clinical pharmacists in antimicrobial stewardship in Asia review. And this study also shows that the Clinical Pharmacist in Antimicrobial Stewardship Program has helped to decrease the duration of antibiotics that is given to the patient, and it's also improved the de-escalation progress in the hospital. And it is actually a combination of several studies, and you can go through this. And from zero, from the very beginning, I was just insisting that from zero. And I just wanted to emphasize again, you can initiate antimicrobial stewardship program at any facility with very limited infrastructure. So start small approach. That's what we have to follow. The first will be seek senior leadership support. Approach hospital management and present AMSP as a patient safety initiative. And you can say that by initiating the antimicrobial stewardship, I will be able to I'll be able to reduce the drug related adverse effects and the mortality. You know, if you work in ICU, you'll be able to see a lot of patients lose their life due to severe infections. So, and these can be reduced if the antimicrobial stewardship program is implemented. And identify a champion. Always it is you alone cannot do anything. You just need an like a motivator or someone to support you. So always it is better to find one or two motivated clinicians or some intensive care physicians, surgeons who can help you with this cause. And currently I'm working in KIMS Hospital, and I say that I have a intensive care physician who actually helps me to implement this process and perform a situation analysis. As I said earlier, it's always better to go for a baseline investigation, and based on that, you can decide what I should focus now, and from that, you can implement it. And similarly, from a you can form a basic committee. The basic committee, you could have a very limited people, like a multidisciplinary committee. Even you can be a part of it, and you can call upon a nurse for that, and you can also have a doctor with 3 to 4 people. If you have a microbiologist in hospital, you can include them, and with this you can form a committee. That could be an antimicrobial stewardship committee, or also if you have an hospital infection control team, you can also include this committee along with that. So it will work good, I guess. And here will be the stepwise process how you can implement the antimicrobial stewardship program. Step one is to perform a situation analysis. Step two, obtain approval of AMS activity. And step three, assemble an AMS team. Step four, set goals. Step five, select intervention. Step six, select key performance indicator. Step seven, implement, educate, and train. Step eight, monitor and report progress. So step one, perform situation analysis. So as I said earlier, it is always better to go for an baseline investigation, and you will have some policies in place. If you are an NABH accredited hospital, you will have some policies in place, and you will have some resources and systems that is already implemented in the hospital. And you know, most of the hospitals have microbiology laboratory services and areas of antibiotic use most in need of improvement. So you just wanted to, what are the facilities you have and what are the infrastructure you have in place, and other than that, you can do an analysis and find what are the areas of what are the areas to be focused now, and the most prevalent multi-drug resistant organisms. For example, if you see that you have multi-drug resistant E. coli organisms grown more in your hospital, then you can focus on that. Why this E. coli multi-drug resistant organism is found in our hospital, and if it is due to some lack of hand hygiene or something, you can implement a process to stop the spread of such infections. And step two, approval of AMS activity. So without the support of the management, you will not be able to implement few things in our hospital. So also as a clinical pharmacist, you will have so much of work like prescription audits, like educating the staffs inside, and you will have to go for rounds. Like you will be occupied with so much of works. And if you wanted to implement AMS activity, you should have some appropriate time for that too. So it is a commitment actually. So if you get an approval from your hospital management, you'll be allotted with the time to do that work also. And once after getting a proper approval, you can call upon few like consultants in your hospital, infectious disease doctors, and also you can conduct some AMS training and education in a hospital with proper approval, and you will have adequate microbiology support for this and IT related support for this. And IT related support is very much important. Like if it is a digitalized hospital, on a monthly basis you can get document from the IT department, like the consumption of antibiotics in OP, IP. So this will be always helpful. So the support of IT is also very much important. So step three, assemble AMS team. So AMS team leader would ideally be an ID doctor, and it is always assisted by the ID clinical pharmacist. And if there is no ID doctor, you can ask some other interested critical care physicians or emergency physicians into this, and you can ask their support. And they could be the leader, and you could be the clinical pharmacist. I mean, clinical pharmacist would be the co-leader. And if there is no one to support you, then clinical pharmacist could be the leader in this committee. So this would be the core team and supportive role. The core team could be an ID physician or a critical care physician who could be the leader. And then you have a clinical pharmacist co-leader, clinical microbiologist, infection control expert, and IT expert. So many people would not know that IT expert would be a team of antimicrobial stewardship team. So it is actually a core team. Many of the studies also suggest that IT expert could be the team of could be in the team of antimicrobial stewardship. And step four, set goals. Like from step one, you can set the goals for the step four. From step one, while conducting the study, you will know what you are lacking. For example, if you are focusing on a ward, like if some ward has a particular uh, more number of infection rate, then you can focus on the particular ward. And if you see that you have an spread of multi-drug resistant organism in a particular ICU, you can concentrate on that unit. Or if you can, and you get to know that from doing a baseline assessment that the antibiotics has been misused in a particular disease or a particular condition, then you can focus on that. For example, if you notice that the antibiotics are being prescribed for the viral infections more, then you can focus on that viral infection condition, and you can make an stewardship program there. And if you find that an antibiotic, sometimes meropenem, is irrationally misused, then you can focus on the particular antibiotic. And sometimes if you feel that the antibiotics are so irrationally prescribed in empirical therapy, then you can focus on that. So like in such a way, you can focus on particular topic and implement one. So this here is an example. Less than or equal to 10 percentage reduction of monthly carbapenem use and a 40 percentage reduction in carbapenem resistant Acinetobacter baumannii infections at 1 year are example of focused AMS program. If you find that the carbapenem resistant Acinetobacter baumannii infections you are getting more in your hospital, and you find that the carbapenem misuse is the reason for the multi-drug resistant organism, and you do some interventions just to reduce the carbapenem use, and by the end of a year you find that about 40 percentage of carbapenem resistant Acinetobacter baumannii infection has been reduced in hospital, which will be an very good antimicrobial stewardship implementation program in your hospital. And step 5, select interventions. Decide which intervention would achieve the AMS program goal most supported by clinical and can be implemented as an available resources. And you just wanted to know what intervention should I choose? How can I restrict the carbapenem usage in my hospital? You have two very important intervention strategies. The first strategy would be prospective audit with intervention and feedback. It's nothing but like hmm, it's nothing but like you do one audit, like, and from the audit you get a report. If the report says you you are actually in this hospital, you are actually misusing or irrationally using meropenem. You just wanted to educate the people inside the hospital that this antibiotic is irrationally used, and instead of meropenem as empirical therapy, you can go for piperacillin tazobactam or something. And another efficient strategy would be, if you find that a particular antibiotic is misused, you will have a formulary with a list of antibiotics. And if you find that this red colored highlighted medicine is misused, then you can restrict its usage. Restriction in the sense, this antibiotic can be dispensed and it can be administered only after a proper approval from the AMSP committee. So you will have an antibiotic approval form. If the prescriber wants to use this antibiotic, he just wanted to justify the reason why he needs this antibiotic. And once after you get a proper reason or justification from the consultant, the AMSP committee would recommend to administer this medication. So these are the effective strategies that will help to reduce the resistance pattern or help to implement the AMSP program. Okay. So if a patient is suspected to have bacterial infection and you just wanted to send the microbiology cultures before initiating the antibiotic process, it is very much important in the AMSP program that the cultures should be sent before initiating the empiric antibiotic therapy. And once the cultures has been sent, the empiric antibiotic can be chosen from the guideline. So it should follow the hospital antibiotic guideline, and it must be documented why this antibiotic has been given and what is the dose, route, when should be stopped, and when it should be monitored, when it should be altered. That should be monitored. And then you can review after 40 to 72 hours. Like if you know, when you send the cultures, the report will be ready only after a 40 hours. So it is always better to review the prescription after 48 to 72 hours, whether the given antibiotic is sensitive to the organism, and whether there is any chance to convert the antibiotic to oral formulation, whether you have any chance to change antibiotic, and whether it should be continued. You can make decision on that. And if the culture is positive, then you can change the antibiotic to the narrowest possible spectrum. If the patient is getting a higher end antibiotic, and if there is a possibility to go for a lower end antibiotic, of course you can go for it. And if the meropenem is resistant to the organism, and you have some other like tigecycline or something that has to be given, then you can go for that. And negative microbiological culture, you need to reevaluate if infection is present. If the culture is negative, you should not always insist to stop the antibiotic. Sometimes the culture test would not be appropriate. So we need to know if the patient is having an infection or not. We'll consider other criteria like procal, CRP, and these total counts, etc. And if it is again suspected to have an infection, we need to continue the antibiotic. If there is no suspicion of infection, we can stop the antibiotic now. And this is the antibiotic monitoring form where the clinical pharmacist should use. So these are the patient details at first, and then we have to mention the date of initiation of antibiotic and why the antibiotic has been given, indication, and then empiric or definitive therapy, whether the antibiotic has been given before the culture therapy or whether the antibiotic is given based on the culture results. And then antibiotic prescribed, what is the name of the antibiotic, its dose, route, frequency, and culture and sensitivity, whether it is sent, we have sent the culture or not. And if it is sent, then we have to mention the date and when the culture report is available. If the culture report is available, yes, and the date of culture report, and whether the antibiotic has been initiated based on the hospital antibiotic policy, yes or no. And if no, we need to know the justification from the consultant. And de-escalation considered after culture and sensitivity, whether the antibiotic has been properly de-escalated after the uh, culture report. And we should know the duration of therapy at the beginning of the initiation of antibiotic. The duration of therapy cannot be planned based on the patient's outcome at that time. Always, while initiating the antibiotic, the duration of antibiotic must also be mentioned in this form. And whether there is any opportunity to switch the IV antibiotic to oral. If it is yes, you can tick yes. And if there is a multiple antibiotic usage to the particular patient, then we need to get the justification from the consultant. And this is for your personal work. Like if you're reviewing the patient on a regular basis, you can write the date and what is the clinical status of the patient while you are visiting the patient. And you can know, you can just also note down whether the antibiotic has been continued or changed. And what is the reason for change? If the antibiotic is changed, what is the reason? Whether the patient is not improving, or whether the resistance, whether this culture shows the drug is resistant to the particular organism, and sometimes the patient may develop nephrotoxicity or something. So that we will change the antibiotics to some non-nephrotoxic drugs. And here you can mention your name and sign. And here again, it is a final outcome, like the duration of antibiotic, how many days the antibiotic has been given, and whether the patient has been recovered, improved, not improved, expired, and whether the treatment is compliant with the antimicrobial stewardship program, and who have reviewed it, and your name, sign, and a date. And step 6, select key performance indicators. Um, like key performance indicators in the sense, during a monthly meeting you need to present an data based on the audit report. So this defined daily dose is like the average consumption of antibiotics, and the days of therapy. This will always show the consumption of antibiotics. And then we have the quality of antibiotic use, like rate of appropriate antibiotic prescription. Whether the antibiotic is prescribed based on the guidelines, then it is yes. And rate of acceptance of intervention. You may suggest an intervention to the consultant or prescriber, whether they are accepting it or not. And then we have the proportion of patient with revision of antibiotics based on microbiology data, and proportion of patient converted to oral therapy. Like as I said earlier, based on culture report, changing the antibiotic based on the stability of the patient. If he is okay, we can convert to oral therapy, and how much is converted to oral therapy, and time to convert to oral therapy. Like the average you will get 3 to 4 days, like that. And microbiologically, the MDR bacterial infection and colonization rate, and Clostridium difficile infection, like in the overall cultures yielded, how many MDR organisms you have found in your hospital. And if you have any Clostridium difficile infection, which is actually a like adverse effect of using antibiotics. So how many Clostridium difficile infection you have, and the length of hospital stay, infection related mortality, and readmission, reinfection rate, antibiotic cost per day. Like as I said earlier, if you are going with augmentin, it will cost around 200 to 300. But well, other antibiotics, it will cost around 50,000 to 250,000 to complete the course. So you can make an audit in these key performance indicators, and you can submit it and discuss it in the AMSP meeting. And from the meeting, you can decide what can be changed or what can be altered in the current practice. Okay. So the step 7 would be implement, educate, and train. Once you have started auditing, and you have implemented few antimicrobial stewardship programs, and again you just wanted to audit that, and you just wanted to know what is again lacking in the things you have implemented. So it is like strategize the rollout of interventions, avoid making too many changes at once by gradually introducing interventions by unit or ward. As I said earlier, you just wanted to focus on one, which is actually taught by my AMSP certification course consultant. He said that it is always better to go for one, and if you are implementing all at once, the physicians will not be able to adapt to everything you intervene. And ensure prescribers and other stakeholders are aware of new guidelines and procedures, and inform and educate prescribers and other stakeholders about AMS activities using avenues such as posters, leaflets, newsletters, lectures, electronic communication, and the hospital intranet. When you introduce something, the hospital staffs, like the consultants or the nurses, should know that it is in place now. And if you are implementing some protocols and guidelines, you just wanted to make aware that the consultants must follow the guidelines. you most of the hospitals will have some intranet facilities or leaflets, and sometimes you can also make some posters and give them. For example, in our hospital we have given the particular customized antimicrobial prescription guidelines to the consultants so that they can follow that while prescribing the antibiotic. And also we have some dilution protocols and other antibiotic selection protocols in our hospital's intranet. Whenever it is needed, the consultants can visualize that and they can make decisions based on that. It must be always available for them at any time. And step 8 is like monitor and communicate AMS program progress and success. Once the program has been implemented, you shouldn't think that your work has over. It is actually a continuous process. You should assess the things that has been implemented by you, and you can always make changes based on that. And you can identify an opportunity to find something that is lacking, and you can use that opportunity to improve further the AMSP course. And monthly follow-up audits and improvements focus. On a monthly basis, you can audit these things like the defined daily dose, which I've said earlier. It is actually a calculation of DDD, meropenem, and the World Health Organization have given an code, or it is an actually average consumption per day. The code has been given by WHO, and you can do that. And this is actually calculated by you. We have a formula for calculating DDD. You can search that on internet, and you have some softwares where if you give the values, that is a total number of meropenems used in your hospital during that month, and the code given by WHO, the software actually calculates its own, and it can give you the entire result like this. And surgical antibiotic prophylaxis, the choice, duration, and time of administration can be calculated. Like the choice of antibiotic would be different for the different surgeries. Some like ortho surgeries, they will take cefuroxime as pre prophylaxis antibiotic, and the gastro surgeries will choose cephalosporin sulbactam as the choice of antibiotic. So it will differ. So you can make a protocol on that, and you can audit that whether the consultants or the departments are following that protocol before surgeries to give the antibiotic. And the duration of antibiotic is like the antibiotic prophylaxis should be stopped within 24 hours, and you can audit that also. And time of administration of antibiotic, the antibiotic should be administered at least 60 minutes prior to incision. So you can also audit the time of administration of antibiotic, and this can also be presented at the Antimicrobial Stewardship Committee. And deviation in empirical antibiotic usage, once you have an antibiogram and you have developed an antibiotic policy, then you can audit whether the antibiotics are appropriately chosen based on the guideline. And then you have duration deviations, and most of the antibiotics is like 7 to 14 days. We must use it for 7 to 14 days. Each condition has its appropriate duration, and the duration must follow the guidelines. If it is deviating, you can make a audit on that, and that can also be submitted, and you can discuss how it can be stopped or reduced. And this is OPD antibiotic audit. OPD, you can majorly focus on the total antibiotic consumption. This is where I said that you need an IT support. If IT in place is supporting you, you will get the monthly consumption of antibiotic in OP. And from that, you can choose how many of the antibiotics are from access category, and how many of the prescriptions are from watch category, and how many of the prescriptions are from reserve category. This is actually provided by WHO. We call it as aware classification. Access is like it is an open group of antibiotics which can be chosen by the consultants. And watch group is like we need some restriction while choosing the watch group antibiotic. And reserve group is like these antibiotics are totally restricted, and you can use only after a proper approval, and it is only if it is properly indicated. And based on this, you can make a presentation. And it is always recommended to choose the access group of antibiotic, and you can make a benchmark. Like in our hospital, the antibiotics at OPD must be from access category, and you can make a benchmark like 85% of the prescriptions must be from access category. That is what actually we follow. And from in our hospital, like initially we had the prescriptions of around 70% from access category, and then we just wanted to improve that. In place, like we have planned to make some personalized cards and give it to consultant, and we have pasted near every consultant. And while prescribing the antibiotic, and we have also educated them that we are planning to achieve 85% of OPD antibiotic from access category, so we need your support, like that. And after that we have seen a major change in the consultant, and we achieved around 78% of prescriptions from access category now, and the reserve category usage has been drastically reduced to 1 to 2 percentage per month, which is actually a great thing that happened to us in our hospital. So in such a way you can focus on one thing and you can do some interventions like what we have did. We have made a card, we have educated the prescriber, and we just said that we need to attain 85% of antibiotic prescription from access category, and just after that we saw the result that it has been improving. So this is how the antimicrobial stewardship program entirely works. You find a fault, you make interventions on that, you educate people, and you finally audit it, and you feel the and you can see the improvement. If it is not improving, again you can discuss with the team and you can implement something else, what can be, what how it can be improved. So this is the only thing I feel you can audit in OPD. And also like sometimes a patient will be given with 2 to 3 antibiotics, like maybe 2 antibiotics, and you can also audit on that whether it is actually needed to, and you can also get justification from the consultant whether these 2 antibiotics need to be given to the patient at discharge, on OPD basis. So these are the things you can do audit, and you can present in the meeting. I think I have completed and I have covered almost all the topics. So no one can escape the effect of antimicrobial resistance. When antibiotics fail, we all lose. That's what actually we should always keep in mind. When antibiotics fall, we all lose. That is, we are currently seeing in our ICUs also, many of the patients die because of the pan-resistant organism. In everyday basis, in every hospital, this happens. So only from proper usage of antimicrobials and reducing the resistance pattern, we will be able to overcome at least a minimum of death will be controlled. So thank you.
Yeah, this is really very much informative session. Yes.
Yeah, thank you.
And
Yes.
yeah, I where is it? Okay, so this is really very much informative session, and implementation of antibiotic stewardship or antimicrobial stewardship can be very much helpful to restricting the use of antibiotic and promoting the rational use of antimicrobials can prevent and lead to the antibiotics resistance in future. And this could be game changing for the Asians, as you
Yes.
have discussed during the session that Asians are going to be leading cause of antibiotic resistance in upcoming future, and because of that a lot of deaths are going to be happen based on the research. So implementations can be done to the hospital by clinical pharmacists, and they can play a vital role in the hospital by implementation of antibiotic stewardship and working in the multidisciplinary settings. So we will be conducting some more sessions on this particular antibiotics
Hmm.
stewardship. In that, we are also going to cover some patient counseling tips and patient counseling points as well. So what a
Hmm.
patient needs to be, remember while taking antibiotics, and how a clinical pharmacist can work on that, right? So we are
Yeah.
going to make some more videos together, and also
Sure,
if
sure.
you, yeah, and it was
It's my
really
pleasure.
a great session, and a practical approach, I could say. It
Thank you. Thank you so much for giving this opportunity to me. I look forward for more such programs from you, and we could collaborate more. Thank you.
Sure. Thank you so much. So
Yeah, thank
we'll
you.
stop recording.